So today I'm June Keels. I'm going to be the facilitator today. We're peeling the onion on a critical and scary topic that's at the forefront of many of the online discussions these days. What's different about today is that we're going to look at, what are these altered standards of care? What do they look like? Where do they come from? How are they applied? And then at the end, I'll do a few comments regarding our self-preservation strategies. So I'd like to introduce someone I periodically work with over probably a decade and also been able to torture during that time on occasion. So Dee Graham has 20 years plus experience as an emergency department nurse and manager, and as a healthcare emergency preparedness manager. She's been a disaster consultant with local, regional, state level jurisdictions on emergency operation plans, managing state level emergency management projects, and coordinating multiple agency exercises. She's a consulting instructor with FEMA's Noble Training Center, and she also has a Juris Doctorate in law. She's a subject matter expert in legal and ethical issues on emergency management, at-risk populations in disasters, and healthcare emergency management. She sits on the Texas State Disaster Medical System Task Force as chair of the Family Assistance Subcommittee, and she is co-chair of the Mass Fatality Subcommittee. Her real-world disaster responses include Hurricane Ike, Alex, and Harvey, the Haiti earthquake, the Reno air race crash, the Ebola outbreak, and the Sutherland Springs massacre. She's currently responding to the COVID-19 event, and she's also the mayor and municipal court judge in her hometown in Texas. So she definitely has a lot of extra time on her hands. So Dee, welcome, and over to you.
Thank you, June. Thank you, Megan. Thank you all for having me on today. I am very excited about this topic, not only because it's something that I've been looking at for a great many years, but also because I feel it is so very relevant right now in what's happening in the world and in the United States. So what I wanted to spend a few minutes on this morning, or in my case in Texas this afternoon, is to talk a little bit about the...
I'm sorry, guys. It looks like we might have lost Dee. I'm wondering if it's an internet connection. She should be getting back on in a moment, but June, do you maybe... Oh, there you are, Dee.
I'm sorry, can you hear me?
We can hear you now. Yeah, you cut out. So go ahead. Sorry.
Oh, did I?
Yeah.
Okay, let me go ahead. And do we have our slide back?
So you'll need to re-screen share that.
Okay. Where did I go? Here I am.
The Zoom toolbar and then screen share. There you go.
There we go. And we'll go back up to the top. We'll find our place. There we go. Okay. So again, what I wanted to talk about today was how the standard of care in this country is not business as usual today. Because it's not business as usual, we are looking at some standards that we've probably not looked at too much in the past. We've had cases of it with Hurricane Katrina, where we've seen deviation from the normal standard of care and looked at things like allocation of scarce resources, triaging based on different criteria than normal. And I'd like to discuss how this potentially, these guidelines potentially create a disproportionate impact on people with disabilities and others with access and functional needs. And I also want to talk a little bit today about some strategies to improve the health equity among populations that are disproportionately impacted in disasters. So what we do know is that historically people with disabilities have been disproportionately impacted in disasters. We saw that very relevantly in Hurricane Katrina. We have seen it over and over again. Generally, where we have seen it, though, is in the realm of response and recovery. So when I say in the area of response, it's not getting people down the stairs if they have wheelchairs and having them wait in stairwells. It is under recovery, making it difficult for individuals with communication disabilities to be able to access certain disaster recovery services and activities. So that's where historically we've seen the disparity in disasters. But we are looking at a new age. We're looking at a new kind of disaster. This isn't about how do we get people out of a hurricane and who goes first and who gets left behind. What we're talking about are really those crisis standards of care, and I'll define all of that in a moment, that may impact individuals in the healthcare setting. And we are seeing this right now in the news. If you are on CNN, and who isn't right now, if you're in CNN, you will know that there is discussion about ventilators and who gets ventilators. There is discussion about vaccines. We know that eventually, hopefully, we will get a vaccine that will manage this particular virus. But it is a pretty good bet we're not going to have enough of those vaccines right off the bat. We saw this in H1N1, where we had a medication that had not been approved by the FDA. It was what we call an EUA, and that means that it is a emergency use authorization medication that the federal government allowed to have used during the H1N1, and that was Tamiflu. A lot of people don't know Tamiflu was not approved at the time of H1N1. So we know that we probably won't have enough resources to get us through what we need to get through. So the question becomes, is who gets those resources? Who gets the vaccines? Who gets the ventilators? And we want to talk about that because this is very real world today and right now and what's happening. So let me go back a little bit. I'm going to put my nurse hat on, or I'll put my legal hat on and my nurse hat on at the same time. And we'll talk about what we mean by standard of care. In the medical profession, we have standards of care that are dictated by professionals, and they define the norms and the requirements by which you deliver care. So if I'm going to start an IV, I have a standard by which I start the IV. I have to use universal precautions, and I have to wear gloves, and I have to do a whole level of standards. And these standards are defined and developed by a lot of the agencies that you're probably familiar with: the American Medical Association, the American Nurses Association, and on the federal level, Center for Medicaid and Medicare sets more. They are the standard-setting organization for healthcare entities. Whether you're a hospital or an ambulatory care or a dialysis center, CMS sets those regulations. OSHA sets regulations for health and universal precautions. Even FEMA has some regulatory requirements in the healthcare field. You are required as a healthcare entity to have certain plans in place: evacuation plans, emergency plans, and those are all set by the national government as well. We also have, obviously, the American with Disabilities Act, which regulates how services, activities, and programs are delivered equally and fairly to everyone. We have the national NIMS. I'm sorry, this is a world of acronyms. The National Incident Management System that talks about how we run disasters and what's the system in place for us to run disasters. There are state laws, there's case law, there is what we call industry standards. Joint Commission and AHRQ are two industry standard setting entities that set the standard of care. So we really have well-developed standards of care for what we do on a day-to-day basis. And that stuff's easy. But what gets not easy is when you have to deviate from these standards. And when would you do that in a disaster? Well, it's usually when you don't have enough staff, enough stuff, or enough room or space. So that's when we get concerned about how are we going to do this? Well, in our current situation, not right now, with COVID-19, we absolutely have a deviation of standard of care because we are talking about who's going to get ventilators. We do have some rules set in place in this country related to standard of care. We don't have that many rules about deviating in disasters. There are some exceptions. An exception is something what we call granting of extraordinary powers. So what that means is on a day-to-day basis, public health departments cannot come in and quarantine you. We have constitutional rights in this country, we have individual rights, and a public health department cannot just come in and quarantine somebody. However, in a disaster, there are accepted deviations from that standard that allows them to quarantine people. We have things called emergency declarations. And when a governor or a president puts forth an emergency declaration, this allows us the opportunity to make different standards. And those different standards might have to do with isolating people or curfews. So we have those exceptions. We have exceptions in disasters to share personal health information, PHI, and that is a deviation from HIPAA, but that is a standard that is acceptable. Can a healthcare facility get bigger than it is? If I'm a licensed 100-bed facility, can I extend that? Yes, you can. You have to do waivers, but you can do that. That's an accepted deviation. Another one that we commonly see is waiver of licensures. So can I, as a nurse in Texas, practice in Louisiana? Well, the answer is yes, I can, because there is a process in place called emergency mutual aid compacts that allow me to go and work in a neighboring state. We also can get, the federal program also has a volunteer healthcare professional emergency program where you can volunteer and you could be deployed federally. And lastly, here's another example and I just spoke about this a moment ago, and that's emergency use authorizations. So you can have a medication that is not currently approved by the FDA, and the federal government can make an exception and utilize a medication as an emergency use authorization if they feel that that is acceptable. And Tamiflu was the example that I just gave. But we're not talking about acceptable deviations here. We're talking about going from what we call conventional care to crisis care. And what we mean by that is this is a strategy for a healthcare system that may be overwhelmed or under stress to identify and select activities that it wants to preserve, and then allow less critical services to degrade. And we're seeing, again, this right now in the United States. Hospitals have canceled elective surgeries. Hospitals have discharged people home earlier than they usually would. This is a system by which we gracefully degrade, if you will use that word, the services that we offer and then make them go down to lesser services. The principle of this is that you want to preserve the functions that are critical to that organization's goal. And any healthcare entity's organizational goal is to deliver healthcare to individuals. So when we look at this conventional to what we're calling crisis standards, and by crisis standards, we mean a substantial change in the healthcare's operations and delivery of care, which is made necessarily by a pervasive catastrophic disaster. And we certainly are in that right now. And when you go to crisis standards, you're deviating from a standard that was established, as we just discussed a little while ago, by peers and rules and regulations. So this is what it looks like from a healthcare perspective. So if I'm a healthcare professional and I work in a healthcare hospital, let's say, on a day-to-day, giving conventional care means that I have enough space to take care of my patients, I have enough staff to take care of my patients, and I have enough supplies to take care of my patients. This is a usual standard of care. We get busy. It's a Friday night in your ER, it's a full moon on a weekend, and it's weekend. we know that we are going to have some stresses on our space staff and stuff. So we go to what we call contingency care. Maybe we don't have all the space that we need, but we can find a way within our healthcare facility to still deliver the care. So we do that in the ER in a very inventive way. We put patients in the hall. Now, do they still get the level of care? Sure, I can give my drunk teenager a MSS basin and in the hallway and manage that just as well as I can in a room. But it is contingency care. Maybe I don't have enough staff, so I'm going to extend my staff, maybe bring in additional staff. That's contingency care. Maybe I'm kind of getting low on supplies. And are we not seeing that right now in the COVID situation? So we find ways to substitute, adapt, conserve, so that we have enough supplies to be able to reuse them effectively and give care. That's contingency care. And in hospitals, we do this, like I said, all the time. We get really busy, we get slammed, we get a busload of people that turn over, and we have multiple injuries. We go to contingency care. But the next category is where I want to focus on, and this is crisis standards. And by this definition, it means that I don't have enough space, that I don't have enough staff, and I don't have enough supplies. And in this current scenario that we are in this country, we're talking about, do hospitals have enough beds for these individuals? And surprisingly, the answer is probably we do. We've talked about running out of beds in places like New York, and bed space is very limited. But the strategies that a lot of our healthcare facilities have used to open up beds, like getting people out early, canceling elective surgeries, is allowing us at this current time in this country, by and large, other than in places like New York, to manage that bed space. That's not too bad. Staff is a problem. Do we have enough trained staff to be able to get in those protective equipment and take care of people? We may not. It depends on where you're at. But the critical area that we're looking at is definitely supplies. We do not have enough ventilators in this country. If this continues down the road, it does, that we are not going to have issues. And I'll talk about some of those numbers in just a second. But I just wanted you to see what the span of how we as a emergency healthcare managers look at the care that we're giving. We go from conventional to contingency to crisis. And this slide is a really old slide. I've had this slide for about, I'd say almost 10 years when I first started looking at pandemics. And these numbers I had to change. The one I had to change was the number of people. We had a few more people in 10 years. But these are statements that were made and were true 10 years ago, that our hospitals tend to operate on near capacity and sometimes on surge. That there is a prediction, this is a prediction 10 years ago. Put this in perspective today. This is a prediction that was made 10 years ago about pandemics, that there will not be enough staff, medical supplies, or equipment. That 85% of ventilators are currently in use on any given day in the United States. Supplemental oxygen will be in short supply should we ever have a pandemic. That no vaccine is presently available for any emergence of a new viral entity. Again, this is 10 years ago. 15% of hospital admitted patients will require intensive care. 75% or half of those admitted to ICU will require ventilators, and 70% of deaths related to pandemics are projected to occur in hospitals. Let me tell you how real those numbers are. Right now in this United States, if you look at the average number of people that are admitted to hospitals, 15 to 20% of them that are admitted for COVID go into the intensive care. In some areas, it's higher than that. It's higher, it's closer to 30, 40% of hospital admission patients with COVID require intensive care. In this country, we are looking at about a 60% rate of those who go into ICU require ventilators. So it's very interesting that predictions that were made 10 years ago prove to be valid even today. The one that is interestingly and sadly very real is the bullet about no vaccines are presently available for any emergence of a new viral. That was 10 years ago, and we still haven't fixed that problem. This is not an area that the pharmaceutical companies are working hard on. And there's a lot of reasons for that. Don't have time to go into it now, but antibiotics and antivirals are not on the top of the list of medications to be made by the pharmaceutical companies. Xanax and Viagra, however, are really popular. So when we look at these numbers and these statistics that were put forth about 10 years ago and see that they're very true, then we have to go back to, if we know that we're not going to have enough staff, stuff, or space, how do we allocate resources appropriately? And some of the key principles, and this is out of the Institute of Medicine, which has done a great deal of work on allocation of scarce resources and crisis standards of care, looks at these particular key principles. One is fairness, making decisions fairly and based on science. And we're going to talk about that in a minute and how maybe that is problematic. Duty to care. We have a duty to plan as healthcare providers, as healthcare systems, to plan for shortfalls. And unfortunately, I don't know that we've done that great of a job in this country to do that. I think if we currently look at where we are right now, more planning could have been done. We all absolutely have a duty to steward our resources, to be good stewards of the resources that we have. We need to be transparent about how we allocate scarce resources, how we're delivering our care, and if we deny care to somebody, we need to be transparent. We need to be consistent in how we make those decisions, and they need to be proportional. In other words, we only make the absolute necessary changes we have to. And lastly, we need accountability. And that means be accountable to best practices for making allocation decisions. The problem that we currently have from a legal standpoint, now I'm going to take my nurse hat off and put on my judge's robe, is that in this country, we don't have set standards of care for crisis standards. We have them for the legal standard of how you start an IV or how you insert a catheter, but we don't have standards of care set out. You can't open a book in this country that says these are the acceptable deviations from care if you're in crisis care. We have some cases that have come out from New Orleans. We have some best practice guidance that's out there. Institute of Medicine in particular is one of those that has put out some really good information, but there is not what we call a bench book that opens it up and says, if you run out of ventilators, here's how you allocate ventilators, and that's the standard. We have guidance, we have recommendations, but everybody is open to do their own thing, and here's the problem. So if I have one healthcare facility that decides my criteria for excluding somebody from getting care is the fact that they're 90 years old, and the hospital across the street says, well, my criteria is you can't get a ventilator if you're over 80 years old. If I'm 82, I know where I'm going. So there is different standards that are out there, and this is problematic. There is a case, an article that just came out recently with the Office of Civil Rights has made a determination that it will drop its concerns about a standard of care that the state of Alabama had out, which said that it would, in looking at its crisis standards, would use as one criteria for excluding somebody from getting care, someone who is quote unquote severely retarded or mentally ill. That is problematic because it on its face violates the American with Disabilities Act, obviously. They're excluded simply because of their disability. And that's what we want to talk about. Let's dive into this a little deeper. So again, as I said, there is not in this country a bench book or a law book that you can open up and it will tell you how to allocate scarce resources. There are guidance. And so what the, for example, the American Medical Association and the healthcare quality guidance says, well, if we've got to look at who's going to get care, who's going to get ventilators, who's going to get vaccines, here's the categories we look at. If I'm going to decide whether or not you get something, I'm going to look at a couple of criteria. Number one, What is the likelihood and duration of the benefit to you of getting this medication or getting this ventilator? What is the change in your quality of life? What is the urgency of need? Do I need it right now? Can I wait a couple of days? This is an interesting one, and it's valid in how we look at scarce resources. Is how much resources will you require for me to save your life or get you on the ventilator? What is your potential to return to baseline state? Some models use age and functional assessment, which is interesting right now in this particular scenario because the COVID test tended to be more deadly for people who are older. And then the other one they look at, and excuse my wrong comma there, is the underlying health or prognosis of the individual. So if I'm standing in an ER as an emergency department doctor, and I'm looking at 3 people, and I only have 1 ventilator, if I use this criteria, I'm going to look at these things and say, let's see, your underlying health prognosis is poor, you're older, you have less possibility to return to a baseline state, you're going to require more resources. Who am I defining here? I'm potentially defining people with chronic medical conditions and disabilities. So from a medical standpoint, if I showed this criteria to a healthcare provider and I asked them based on clinical evidence, based on your decision-making process as a medical person, do you think that this is a good criteria by which you decide whether or not people will get life-saving services? And the majority of medical people says, yes, this makes sense. Why would I give medications or ventilators to someone who has a poor underlying health, is not likely to return to a baseline state, is going to use the most of my resources, and has a very unlikely duration or likelihood of benefit? So taking, again, my medical hat off and putting my legal hat on, I'm going to step on the other side and say, yeah, but you're defining someone who has a chronic medical condition, or you're potentially defining somebody with a disability. And that's the...
Yeah, initially I thought maybe it was just me, and
The other, there's another criteria that looked at, and this is probably much more medical. This is based strictly on looking at the likelihood of mortality or morbidity for someone based on their medical condition. This doesn't look at how many resources you're going to use. It doesn't look at your age. It looks simply at your possibility of being able to survive based on your medical condition. And so if you look at someone and they take into account people's respiratory status, people's coagulation ability, their liver function, their cardiovascular function, their central nervous system function, their renal function, are they in renal failure, are they in liver failure? The higher their score is on the problems they have, the higher the likelihood of mortality, and that puts them on the lower end of receiving life-saving or scarce resources. So that's kind of what's out there right now in the medical community as guidance for how we look at, how we allocate resources. And unfortunately, I don't see in these decision-making processes, in these conversations, I don't see a lot of disability advocates. I don't see a lot of whole community involvement in this process of understanding that people that are going to be most affected by this decision-making process are not sitting at the table. We've got a lot of medical people, we've got really smart medical people there, but that doesn't, that is not a whole community approach, because they don't understand a lot of times the implications that this has to individuals and how it discriminates against an individual just because they have a disability or they may be older. So we want to look at some potential strategies to improve equity and to ensure that there is a whole community approach to this. we're going back to the Institute of Medicine, and it makes recommendations to the healthcare entities that if you're sitting having conversations, and I will tell you folks right now that these conversations are going on right now in hospitals all over the United States. I have had multiple calls from healthcare coalitions, from healthcare systems who ask, what criteria do I set? Where's the information I need to make these decisions? And IOM talks about things like, obviously you want to employ ethical considerations. They can't be about, they have to be fair. Those ethical considerations that I mentioned before, being transparent, being consistent, being fair. And then the other problem that concerns us is that when you're developing individual standards at individual levels, that means every crisis at one location is determined differently than another location. And some of you may have heard about Hurricane Katrina and Memorial Medical Hospital, where doctors made decisions about giving medications to ease the suffering of some of the patients they were going to have to leave behind. Those patients died. And the conversation about why did you make those decisions and what were those decisions you made when there was a hospital that was right next to Memorial Medical that was in exactly the same situation, made different decisions, and nobody died. So we also look at clear legal authorities, making sure you understand your legal background and your legal landscape, that you establish clear indicators and triggers, and you have evidence-based processes, that we have evidence that we can go by. Because again, if you're sitting in my court and I'm making a determination about why did you decide to do this, why did you do what you did, it has to be based on clinical processes. And lastly, community and provider engagement, education and communication. So bringing the whole community into the team, participating in ethical consortiums. That means healthcare coalitions. Hospitals have ethic teams. They should have representatives from the disability community involved, discussing those potential issues so that the healthcare side can understand the concerns and the complications that could arise. And then educating affected populations about these issues, because this is not a conversation we're having and we're not having it enough. This is an unprecedented situation. We have never been in this situation before that we are in today. We know that it's not going to get better. It's going to get worse, and then it's going to get better. And we're going to continue to have pandemics. There is some prediction that this pandemic may come back in the fall when the weather is once again bad. So we have to think about how we're going to plan to ensure ethical issues of health equity are discussed, and all the participants that need to be involved in it are involved in it. And we use a whole community approach to bringing in all the members of the community that are affected by this, not just people with disabilities, the whole community. So I'm going to turn this back to June, and it's her turn. And thank you for the time that you let me spend with you. I'll give it to June.
Okay, well, Dee, that was, thank you, that was excellent. And it was sobering, to say the least, but it really did bring into sharper focus the details of these altered standards of care. You know, you mentioned that book, 5 Days at Memorial. I do recommend it for any of you who are interested in a deep and another sobering picture of what happened during Katrina. So it's called 5 Days at Memorial. So I just want to spend a few more minutes focusing on planning for our own self-preservation in terms of a hospital stay and our strategies. And then we'll get to lots of your questions and discussion. So some good news here is that there have been quite a few legal challenges lately that have successfully challenged states with healthcare system policies that explicitly use the existence of disability as a criteria for deprioritizing an individual for life-saving care. So there have been some major dents, successes, and one is this first bullet on the slide, which is the Department of HHS, Health and Human Services, in response to one of these formal legal complaints from disability advocates, did issue guidance that hospitals cannot ration treatment based on disability status. But I think we all know, we're not naive, that that's not enough to ensure that there won't be discrimination. So there's been lots of activity in this space over the last months. And I think, go back to slide 2, slide 1 here, sorry. There's been a lot of work. On Friday of last week, AAPD did an excellent seminar on this, and the recording and transcript is a link in the slides that you will get soon, and as well as on that link at bullet 2. So all of these complaints have been aimed at enforcing what disability discrimination laws require for healthcare systems to make sure that they're not acting with bias and they're not underestimating the quality of our life just because they're dealing with people with disabilities, and that they're not making individualized decisions based on implicit bias, but on more objective evidence. So at the end of my slide deck, there are 2 more slides on rationing related resources, and they are appearing fast and furiously. So I've not been able to keep up with all the resources, but at least it'll give you a sense of what's out there. So in terms of our self-preservation, many of us encounter disability-related problems and implicit disability bias when we're in the hospital. We need to focus on understanding that, as Dee explained, in this chaotic COVID-19 hospital environment, we've got to think through strategies regarding planning for a hospital stay when business is really far from usual. So our rigorous advocacy, rightly so, has been focused on keeping us out of the hospital, planning for avoiding getting sick, and when needed, managing being sick at home, and maybe even getting that oxygen needed at home if we can. So over planning is good, including planning for the worst case, which is needing to go to the hospital. So on slide 2, oops, why does this keep happening to my slides here? Slide 2. Slide 2. So preparing for dealing with staff that may hold those disability biases and about the quality of our life, you need to really think about worst case scenario, having a hospital survival plan. Plan for being, unable to think or communicate clearly, because you need to count on, if you need to go into the hospital, you are really sick. And what we've learned is that with this virus, getting real sick tends to come on very, very quickly. It's not gradual. People go from just sick to real sick. So one of the things that we're recommending is that, given the infection prevention rules, you probably won't be without your usual support team. So check ahead of time on your policies, the hospital that you may have to go to regarding policies allowing someone to go with you. They tend to vary considerably, sometimes can be challenged in terms of your needing an accommodation, but frankly, they're all over the place. So one critical strategy is having a contact list that you bring with you, a hard copy where you list in priority order the cell phone number with text capability of your contacts, your advocates, people you discussed with what you want done, people who can remotely advocate for you, counter implicit bias, and people who understand your advanced directives. You need to also put together for the worst case scenario a grab and go hospital bag kit. And you need to do this now, because when the time comes, you're not going to be up to doing this. So do it when you're sharp, when you're well, when you can think clearly. So in this kit, in this grab and go thing, a real critical piece of advice is put hard copies of what I'll go through real quick in a Ziploc bag that you can attach a streak to and put it around your wrist or around your neck, because things quickly disappear in hospitals and you want that available to you. So in your hard copies of what you'll take with you, besides the usual health insurance cards, ID, driver license copy, whatever, on slide 2, number 1 here is create your emergency medical information. What's your critical health care information? Your medications, equipment needed, allergies, communication needs, medical providers, advanced directives, etc. Another thing that you may not have thought of, but it may be critical, is for those of you who have been a visitor or a patient in a hospital, you often see signage above the bed of a patient. It'll say something like, fall risk or diabetic or whatever. But create your own signage that they can post. For example, call Marcy at this number. She can talk for me, or I'm hard of hearing or blind. The other thing is to have some communication sheets, preferably in a plastic sleeve, and I'll go over those in a minute. Keep the stuff close to you in a bag so it doesn't get lost. Keep your cell phone close in a bag so it doesn't get lost. Again, preferably in a leash around your neck or your wrist, because again, things disappear. Bring your medications, even though sometimes they won't use them. People are still comfortable having them. And bring a Sharpie right on your skin before you go anything critical, like diabetic or blind or whatever. Bring your phone chargers. Now on this slide 2, number 2 and number 3 are excellent resources with the links that you can access later. These are very current, good advice kinds of documents for people with disabilities during COVID-19. Really excellent survival strategies. So I urge you to look at all of them. They're very, very good. The other thing I want to just highlight real quick is bring communication tools that will work for you. If you're on oxygen and in an ICU, you indeed may still be able to communicate. But if you're on a ventilator, then you will not be able to communicate. So I included just a sample, a variety of communication tools, and these are some of the links where you can get more information. But basically, these are tools that allow you to point in terms of communication or allow somebody, a healthcare worker, to help you communicate. There are yes, no tools, and again, good instructions for the healthcare worker to help you use the sheet if you are unable to point or you're not able to indicate with a yes or a no using a blink system or a finger system. So just a variety of really good kinds of tools. Pick the ones that work for you. There's just a variety here. I'm not going to narrate them all. This is a word board, a letter board where you can spell out keywords. I like this one. This is a blank one, but you can put your own messages into them. So I was just playing around, like need my phone, or call Marcy, or need my glasses, or now if I'm on a ventilator, chances are I may be kind of out of it or in some kind of sleep state, or they give me propanol. But if I can communicate, customize your messages that you anticipate. My back hurts, change my position, I need the call button, I need an ASL interpreter, whatever. And at the end of these slides are just a bunch of other resources. Again, they keep reoccurring, but they are really important to look over. And again, back to those communication tools for a minute, recommended that if you can, make several copies of the ones you like, put them in a plastic sleeve. Remember those old sleeves we used to use when we'd make transparencies for slides? You can use those, you could use Ziploc bags, but whatever works. And Sarah Blackstone, who I got many of these from, may want to comment about these more during our discussion. So I think that's it. And Megan, I'm gonna turn it back to you. I think we're ready for discussions, and I know that people can raise their hands in chat, or to dial 9 to raise your hand if you're on a phone, and if you're called upon, then it's *9 to raise your hand on the phone, *6 to unmute your line, and there's a raise your hand, I think, in the chat part, in the chat area. So
Great, June. Yeah, that is correct. This is Megan again at CFILC. So if you guys would like to ask any questions verbally, it is *9 to raise your hand, or if you're on the computer, if you hit the Manage Participants button, or I'm sorry, View Participants, there will be a raise hand button that'll show underneath the participants, or you can use the Alt key with the Y key at the same time, so Alt Y. But we do have some questions that have already come through. There's been a lot of discussion, so let me go ahead and read some of those back. Ruthie once commented, she said, the rush to judgment by this administration in determining what drugs are to be handed out and the decision by non-doctors appears to have a collateral damage projection they are not mindful of. Is this an acceptable application of the emergency alternate use of medications?
This is Dee. I'll jump in and try not to be too political. Us judges aren't allowed to do that. However, when we went back to what we talked about earlier about our duty to plan and our duty to be prepared, we have seen, unfortunately, multiple examples of the federal government's inability to access resources that are available. We keep in this country something called a strategic national stockpile that is available. It has things like ventilators and medications, not necessarily ones that are applicable for here, but it has resources. And it is shown that it has been very slow to how it moves and how it manages that process. I agree with you, and it's not just because I'm a nurse, but I agree with you that there needs to be the right professionals in the room when decisions are being made about medical care, and I've not always seen that. So if that's a good legal answer that didn't really answer anything, that's my viewpoint on how I'm seeing things coming through in this country right now.
Great, thank you, Dee. We have another question here from Lilibeth. She wants to know if you have any suggestions on how to join the panels or get involved as a decision maker about the protocols hospitals have in place.
Well, I can speak to this, but I think June also can speak to this as well, because June happens to be one of the better examples that I know of somebody who has made their way into the emergency management forum, into the emergency management rule, and has taken the disability issues and considerations into that arena. So she can probably speak to this much better, but it is being aware of what your legal landscape is. Who makes the rules about emergency management in your jurisdiction? Do you know who your emergency manager in your county or city are? Most people don't even know who that person is. Most people don't know that a lot of your emergency management programs that they have do require that they have people from the community sit on those boards and sit on those different organizations. So again, understanding what you have in your community, what kind of programs and who runs those programs and who does the emergency management is a good way of interjecting yourself in there. And the same way with your healthcare situations. Most communities have healthcare coalitions, and on those healthcare coalitions sit a lot of different people, and that's a good way to get in.
So Dee, I would just add to Lilibeth's question and throw it back to you. In terms of these ultra standards of care and being at the right table to impact the triage team's protocols during these difficult times and to prevent some of these implicit biases from rearing their ugly head, it seems difficult to get to each different hospital table to do this during a time where we've got multiple balls in the air in terms of our advocacy bandwidth. So I throw it back to you, how do we achieve the biggest bang for the buck given limited bandwidth and not able to get to every single triage team table at every hospital?
Really good point. We have such diversity in this country. We have rural settings, we have very urban settings, and you're right, the bandwidth is very limited. One of the things that I find troubling is that we have had so little discussion about this issue that they are having conversations at the hospital level. And frankly, that is not the level that these conversations should happen. Because again, as I said, if you have a hospital A has one criteria and hospital B has another criteria, how do you determine which one is the correct criteria? Is one more fair than the other? Is one more equitable? And when you're doing it at that level, that is not how you make guidance for the nation. Quite frankly, the conversations about crisis standards of care need to be at the state and federal level, because the state can set tone. The federal government can set tone, but when you have each individual hospital setting tone for what they think is fair or unfair, or is right or not right, you're going to get Memorial Medical Hospital in New Orleans all over again. So I think it needs to start at the state level. I think that if you have representation at the state level, that's a good place to be, because that's where your voice is most likely to be heard.
Thank you, Dee. We do have a couple more questions that have come through. So Margaret wants to know, what can we do to prevent hospital staff from taking ventilators away from people with disabilities who are long-term vent users and giving them to people who are judged to be more worthy. Dee, it looks like you're muted. We're not hearing you.
Well, I'd get a real big stick and I would carry it with me when I go to the hospital. Again, this is conversations that it's difficult to have at the local level when you're walking into a hospital trying to explain to a very frazzled nurse who doesn't understand any of these issues, doesn't understand about your disability, doesn't understand that your disability is not the same as other people's disability, is really not the time to have that conversation because you're not going to win. The time to have the conversation is, again, at a higher level, at the decision maker level, because that nurse, that hospital probably doesn't have the ability to make that decision on an individual basis. Again, we need to do this at a higher level. We're talking to people who can make the change, understand the issues. And one hospital setting that can do that is their ethics committee. Almost every single hospital has an ethics committee. And this is just a recommendation, if you went into a facility and they told you you cannot bring your caretaker with you because we're not allowing anybody to come in, or you can't take some piece of equipment or assistive device that you need because they can't clean it or whatever, they're worried about decontamination, I would, as a advocate, as a patient advocate, I would say that the patient should ask the hospital to convene their ethics committee, because the ethics committee hears these individual cases, and it's your opportunity at that point to make that argument and make the case for why you're not doing this equitably or you're not being transparent, whatever the issue is. Every hospital has to have an ethics committee.
Thank you, Dee. Our next question comes from Lisa. She says, how are advanced directives factored into crisis care? If an advanced directive states a person chooses not to have extraordinary life-saving measures taken, I doubt they were thinking about how this would play out in a pandemic. Are hospital workers disproportionately asking for advanced directives from people with disabilities?
Hopefully not. It is a requirement that every person who comes into a healthcare facility, regardless of disability, medical condition, is asked, do you have an advanced directive? And so that should be applied equally across the board when patients come in. Do you have an advanced directive? And if you do, we need a copy of it. I personally have not heard of cases where healthcare entities are pushing directives on people with disabilities. I would not doubt that there are conversations going on, especially in New York, about people that the medical personnel are looking at and saying, your overall health, going back to that SOFA score that we just talked about, your overall health and your underlying conditions puts you at a higher number on the SOFA score. And that SOFA score means that you have less of a likelihood of surviving this. That is, I would not be surprised if they're having those conversations, but I would be very disheartened if I was hearing that healthcare providers were pushing advanced directive on people with disabilities. I would hope that's not happening.
Thank you. And again, for folks that have more questions, please feel free to put them in the chat or raise your hand on Zoom. It's *9 or Alt-Y to raise your hand. We have a couple questions and comments here from Lilibeth. Her first one is, do the hospitals have communication devices?
Well, yes and no. To the extent of having the assistive technology that we're accustomed to having, no, they don't. They have limited picture boards. They, of course, have access to interpreter and translator services, but the assistive technology is very limited in most facilities.
Thank you. And then her other question or comment is, would going to the AMA chapters and or nurses associations be a good addition to the strategy, I think, of bringing disability to the discussion?
I absolutely think so. Any opportunity that you have to raise your voice to any entity that makes the guidelines, Again, the Institute of Medicine is the premier area that's setting guidance. But as far as conversation about standards, American Medical Association, the American Nurses Association, any of the associations for trauma doctors, all of those entities that do accreditation and certification, any access you have to talking with them is helpful.
Thank you. We have a few more questions that have come in while I get those sorted. Sarah Blackstone, you have your hand up, so please go ahead.
I actually have a comment or two. I've been involved in the development of that patient-provider communication materials that's located on the website. And one comment I want to make is that the people that have been involved in doing that represent well, it's an interprofessional effort, and so there are nurses and there's speech pathologists and there's engineers and there's psychologists that have been involved in putting those materials together, and they're evolving as well. In one area that we haven't quite put up yet, but there is some material about medical decision making that's up there already, but there's going to be more materials available. And also, many of the materials are available in multiple languages. So the communication issues that confront individuals in this COVID environment, it makes everybody equal, because the right to communicate and the difficulty that people who have COVID have in communicating is shared because of the difficulty not only in patients being unable to use their natural speech, but also because nurses are dressed fairly extensively, which means it's very difficult to understand what they are saying. And communication is the joint establishment of meaning, so that it's quite helpful to have other ways of communicating in the intensive care environment or even in the hospital. And I just want to follow up on what June said, which is really you can't predict, but you can prepare, so that I think any of us can prepare to take with us if we have to go in the hospital or we have to be at home, to prepare for the fact that it might be very difficult to communicate with individuals who are taking care of you, and that the likelihood of you have access to anybody who knows you is extremely slim, given the conditions that people are now under in hospitals.
That's very true. That's a very good point.
Thank you, Sarah. This is Megan. We have about 20 minutes left. We have a follow-up question here actually from June. She says, during the chaos of COVID-19, will the hospital actually have time to convene their ethics committee?
Again, I think that it is situational. I have not, again, New York City is such a outlier for what we're seeing as far as the numbers are concerned. They've just been so overwhelmed. And you're right, it is it's difficult in times of disasters to know what services that there are still going to be around. I would bet, however, that of the essential services that hospitals have right now, one of them that they totally want to keep is their ethics committee, because it isn't just this ethics issue. We have ethics issues all down the road here, and it's related to, are we going to have enough blood services? We are short on blood right now. So how is the hospital making decisions about who gets blood? How is the hospital making decisions about if a staff member gets sick? So the ethics committee has a pretty heavy lift right now in this particular situation. So I would think they would be more prone. If I was a hospital administrator, I would want my ethics committee at my side, or at least a phone call away for all of the issues, not just this particular one.
Thank you. We have a question here from Meg. She says, can you describe the ethics of how the triage team is composed and involved in scarce resource allocation decisions?
So when we talk about triage in extraordinary circumstances. We have two kinds of triage. We have triage that on a day-to-day basis, if you walk into my ED and you're having chest pain and you're a little blue and it's going up the right side of your arm, I'm probably going to make you a number 1 red. You're my red patient. In disasters, when we have, again, either limited time or limited resources, we tend to make decisions in triage based on most survivability. Frankly, that's a military model. It comes from years of experience. So what that means is that if there's an airline crash and I go out there as a paramedic and you are not breathing, I may be able to stop and give you CPR, but I'm not going to. Because A, your survivability is one of the least, and B, because I have 100 other people that I have to take care of, and I need to triage you according to your best survivability. So when you talk about the triage process and crisis standards, what we are truly looking at is how do we make the best use of the resources we have to the people that are most survivable. And that's where you get into that tricky models of what does that look like? Does that look like the SOFA score that I talked about? Or does it look like the AMA model that considers social issues such as quality of life? Quality of life for everybody is so individual. But we make assumptions in the healthcare community. If you talk to a number of doctors in the hospital and you talk to them about quality of life for someone with a severe disability, then they see it from a medical standpoint and say, no, I wouldn't want to live in a wheelchair on a breathing tube. There's no quality of life there. But if you talk to the person that's in the wheelchair, their definition of quality of life is different. So when you're looking at it two different eyes as to what is essential and critical and what is those other determinants in quality, they're very different depending on who's looking at it.
Thank you, Dee. And I think to tag on to that, Meg also asked, June, can you provide a brief overview of emergency operation plans, ESF-8, and pandemic flu components?
This is June. Sure, I can. Do you have the rest of the day for that? ESF-8 is health and medical, and I'm not able to really address the full scope of that question, but I can tell you that as an advocate and as with other advocates, our frustration about ESF-8 is that it's very hospital-based, and the majority of us are dealing with health issues in the community. And because of that, we've had some real gaps in the way, we apply the kinds of services that are needed right now so that we can avoid institutionalization in hospitals. So that's one of our major frustrations. I'm not able at this point, Meg, to go deep with the rest of your question, but I would wager a guess, and Dee, you might want to pipe in that there would be a scarcity of standard of care issues in ESF-8. But over to you, Dee. Anything to add to that?
Sure, and June's absolutely right. We don't have all day. We can talk about this. What you're referring to, for the other folks that aren't real familiar, ESF-8 is an essential emergency support function by which the government categorizes the functions that are critical in disasters. And ESF-8 is public health and medical. And it designates the rule or the responsibility of public health to manage medical and public health and mass fatality disasters in disasters to the public health department. And everything falls under that. And again, these are the people that should be having these conversations, and unfortunately they're not.
Thank you. This is Megan again. Lilibeth is asking, in the hospital chaos, we need the support of our personal care assistants because most of us are often put to the side until they're ready for us. Are we allowed to bring personal care assistants or have them with us?
That's a great question. And one of my peers who's also on this call was telling me a story just the other day about an individual that she spoke with who had been told that he would not be permitted to bring his caretaker with him to into the hospital. Again, we need to advocate and help the hospitals understand the role of that caretaker and what they provide for us that the hospital cannot. And again, this is an example where if I had the ability to request that the hospital ethics committee convened so that they can consider this matter, then this would be a good example of doing that.
Thank you, Dee. We have another question here from Todd. He says, Dee, advocates across the nation want to have some kind of access to the patient while in the hospital. From in-person to electronic, what can we ask our states to consider as a policy for patient rights?
I just think there's so much there's so much noise going on right now at the state level, at the government level, that hearing another side of the story is going to be very difficult. And having that voice in the middle of the disaster is so hard because to a lot of the officials and a lot of the people making decisions, it's just one more voice. And again, it's going back to talking about these conversations need to happen before the disaster. These conversations need to have been discussed before the emergency, and it's very hard to get that message to people right now. And this is just so reactive. We see this all the time in history when we have situations where people identify there's a discriminatory practice and it's happening right now, and we can't discuss it until after it happens, and that's problematic.
Yeah, I want to add or ask you more about Todd's question. What's the reality of our expectation that a healthcare worker would be able to help us dial the phone, for example, if I wanted to talk to my advocate, Todd? What's the reality of that kind of thing happening?
Without there being a COVID situation, has anybody been hospitalized lately? If you have, you know that on a good day, it's hard to get someone to come into your room and help you with things. I would magnify and amplify that by exponentially right now. That I believe that in some locations, especially in the higher acuity areas like New York, getting people just to be seen and admitted and taken care of, much less providing additional services, which is the conundrum. This is a time where you would need your health care. This is a time where you need your caretaker or your personal assistant more than any other time. And it makes sense from a nursing standpoint. If you came in and you had your caretaker with you, you've just made my life easier because I don't have to come and run in your room and help you eat or help you get to the toilet. You have somebody that does it. This is a model that is done repeatedly in other countries. It is very common in other countries that family members help take care of the family, that the daughter or the son come in and help feed the family member, help them with their activities, daily living. And we fail miserably in this country in doing that because it just makes everybody's life harder.
Thank you, Dee. And this is Megan again. We have about 10 minutes left here. June put a really great question in the chat. She said, I've heard very little about the role of healthcare coalitions during COVID-19. Can you share with us any success stories or at least what they should be doing?
That actually is a great question because it goes back to what we were talking about before. If healthcare entities on an individual basis are making decisions, then those decisions are going to vary from facility to facility. Again, we need to look at this on a much larger scale, and healthcare coalitions are the perfect place to do this because healthcare coalitions have the ear of all of the hospitals. They have the ear of all the public health folks that are sitting in the room. They have the ear of all the members that are sitting in the room as part of the coalition. So it's an excellent opportunity for all of the healthcare facilities to hear the same message It's an excellent opportunity for all of the healthcare facilities to be able to express their concerns, and healthcare coalitions have people sitting at the table that can make decisions, whereas they might not be able to make decisions on the individual hospital level. So absolutely, healthcare coalitions need to be the place where we start this dialogue and have that dialogue. And it's actually in a lot of the guidance for healthcare coalitions. They are actually required in something called the FEF requirements, the Public Health Emergency Preparedness and the Hospital Preparedness Program, in order to get funding for your healthcare facilities and for healthcare coalitions. They are required to have plans for this. And in the language of those requirements, it uses the word, talks about altered standards, and it talks about planning for people with disabilities and planning for vulnerable populations such as children and elderly and people with medical conditions. That language is already in there, that those healthcare coalitions are supposed to be doing this planning.
This is Megan again. We have another follow-up question from Todd. He says independent living center staff can enter skilled nursing facilities during non-pandemics to advocate for patients. What about now, and also including hospitals?
Wow, I would be very surprised if that exception was still permitted at this point in time in most of your facilities. There is such a restriction, and we haven't even talked about skilled nursing facilities who are struggling so much more than hospitals are because they don't have the reserves of staff, because they don't have the reserves of supplies. They are truly struggling with infection control because of the kind of congregate settings that their patients are in. You can be in a private room and or a room with two people in a hospital. Healthcare settings have much more congregate settings, and that is one of the reasons there's so much exposure and so much contamination that we're seeing right now in some of these facilities that have almost everybody in the facility ill and the staff ill. They don't have the isolation capabilities that hospitals do. So my answer would probably be, in this particular setting and in this environment today, that is probably not happening. There's probably not permission being given to have folks come in that are not either the patient or a direct family. And even direct families are not being permitted in many facilities.
Thank you, Dee. And we have about 7 minutes left here. Meg has a rather long question in the chat. It's about the HHS guidance on optimizing ventilators. And she wants to know if we might receive a lower standard of care for people that are expected to use personal equipment and not given the ICU ventilator.
So that's a great question, and I've been reading some guidance on that. And there have been some recommendations. There's been a lot of ideas about how do we maximize ventilators, and there's some good strategies. For example, people that are on ventilators often are on telemetry machines, and you have to monitor their blood gases, and you have to have them on O2 sensors. And there's a lot of conversation about how we can use a little less technology on that, and maybe instead of using a telemetry machine, have the person on a pulse ox that tells you that if their oxygen level goes down, they've got a problem. So you save some machinery. The problem that we're looking at, that's a lot of discussion has gone out about, is can we either double up on ventilators? That's the biggest thing that's coming out right now. Let's double up on a ventilator, put two people on a ventilator. Is that possible? Absolutely. You could take a Y tubing and you could crank up what we call the PEEP, and you could crank up the O2 levels, and you could put two people on a ventilator. Is it a good idea? Absolutely not. There are so many problems with cohorting on a ventilator, the least of which is passing diseases to each other. You no longer can put a ventilator to just one setting for one person, so you may be overventilating one person and underventilating another. So that whole issue of how we can maximize ventilators is very tricky right now. And again, some of the conversations are, well, maybe we just need to make criteria for who gets a ventilator and who doesn't.
And tagging on to that, Dee, Lilibeth has a question. She says, if we already have our own ventilator at night, can we bring them to the hospital while we're being treated?
If you were coming to my hospital, I would tell you absolutely. If you've got your own stuff, why would I want you to not use your stuff and only use my stuff? I think that makes great sense. However, I would say that many of your hospitals have not reached that level of free thinking and would allow you to do that. That is a good question, though. I've not had that presented to me, and that would be a really good thing to ask some of your healthcare folks. I would say from a risk management perspective, infection control management, they would have issues with that. But frankly, there are some things that we need to let go of in this scenario. And infection control is one of those things that we really should be relooking at and how we can manage the infection control issues so that we can maximize using resources.
Thank you. And it looks like we have somebody with their hand raised, and we should have time for just one more question. So if your phone number ends in 9511, please go ahead.
Hi, yes, I was just wondering, is there a risk of the ventilators, like your personal ventilator, being reallocated if you do take it with you to the hospital, if they determine there's someone that they think should be receiving the treatment beyond you or above you?
I would hope not. There are, from so many perspectives, that's wrong. It's wrong from the perspective of ownership. It's wrong from the perspective of if they're using your ventilator, what are you on? That's concerning. But I would think from an infection control, simply from an infection control standpoint, that is not a good infection practice. There's no way that they could deep clean that ventilator well enough to satisfy them that one person on it going up to another one, to be totally sure about that. I think that would be prohibited from an infection standpoint.
Indeed, I want to add that we have heard some reports of that. How true they are, I don't know. But Megan, I just wanted to take an opportunity to close
Let me do it.
and thank Dee for a great job in helping us to think about our next advocacy steps and shedding light on a difficult topic. So thanks for an excellent job, Dee. And just wanted to remind all of you that we will be posting a recording and the slides, and the website is disabilitydisasteraccess.org. I know that's a mouthful, but it's also in chat, disabilitydisasteraccess.org. Our next topic will be in May 14th, and it will be about COVID-19 and what's happening with our peers internationally and what can we learn from them and them from us. And that'll be done by Marcy Roth, the Executive Director of WID. And our next status call, where we do briefings and situational awareness, will be on the fourth Thursday of this month. And if you want to sign up for these notices, how you do that was in the invitation for this session. So again, Dee, thanks a lot, and thanks to all of you for joining. And
Thanks for having me, June.
back over to you, Megan.
Yeah, that's everything. Thank you guys for joining, and we will have the archive up shortly. Stay safe and have a good rest of your day.